Welcome to the session on reducing alcohol-related chronic disease through non-governmental organization and government collaboration. This was presented at the Chronic Disease Prevention Alliance of Canada conference on February 9th, 2012 in Ottawa. My name is Denise De Pape. I'm the Director of Alcohol Harm Reduction in the BC Ministry of Health, where I've been working for over 3 years. Before that, I spent about 25 years in public health in Ontario, most recently in Toronto Public Health. This presentation is the fourth in a panel on alcohol as a risk factor for chronic disease. Slide number 2 is an outline of the presentation. Slide number 3 is presents a number of key messages that I would like to make. There are over 60 medical conditions with alcohol causality, many of which are chronic diseases. The evidence continues to accumulate. Alcohol as a risk factor for chronic disease has been neglected for far too long. The other 3 speakers in this panel have provided plenty of evidence for taking action now. Anything which reduces population consumption levels of alcohol will reduce alcohol-related chronic disease burden. We need the chronic disease community in order to make this happen. Work is underway to reduce the global burden of alcohol at many levels in the world. The first level I want to discuss is global. Since Canada has endorsed the Global Alcohol Strategy when it was adopted at the World Health Assembly in May 2010, it is incumbent upon us to take action at all levels across the country. Alcohol is one of the 4 most common modifiable and preventable risk factors for chronic disease. The other 3 risk factors are those with which most people are familiar: unhealthy eating, physical inactivity, and tobacco use. Tobacco is the leading risk factor for deaths and disabilities as measured by DALY's, Disability Adjusted Life Years. The second leading risk factor for deaths and disabilities is alcohol, a fact which surprises many people. Some of the information about alcohol and the burden of alcohol has been presented in more detail in Dr. Norman Giesbrecht's slides. But what I wanted to emphasize is that the Global Alcohol Strategy presents 10 evidence-based areas or interventions for action to reduce the harms and costs of alcohol. Slide number 6 identifies these 10 interventions or policy options or strategies. I've highlighted in bold those where there is potentially some role for organizations and networks which are focused on chronic disease prevention. So we have the Global Alcohol Strategy, and we have a National Alcohol Strategy. It was developed by a multi-sectoral group under the leadership of Health Canada, the Canadian Centre on Substance Abuse, and the former Alberta Alcohol and Drug Abuse Commission, which no longer exists. It's been absorbed into the Health Authority. Anyway, as you can see from this slide, the title is Reducing Alcohol-Related Harm in Canada Toward a Culture of Moderation, with recommendations for action, released in 2007. In the National Alcohol Strategy, there are 41 recommendations. They're organized in 4 categories. The first is health promotion, prevention, and education. The second is health impacts and treatment, and there is a specific recommendation in that section on chronic disease. The third category is the availability of alcohol, and the fourth is safer communities. There's a National Alcohol Strategy Advisory Committee which leads implementation, monitoring, and evaluation, chaired by these three groups listed on slide 8. Slide 9 lists the members of the National Alcohol Strategy Committee. Two of today's panelists are members of NASAC, as we call it. One is Dr. Robert Strang, who represents the Council of Chief Medical Officers of Health, and I represent the BC Ministry of Health. Note, please, the broad range of perspectives, including the alcohol industry. And I just wanted to tell you that just recently, February or March of 2012, the Canadian Public Health Association, which is a member of the National Alcohol Strategy Advisory Committee, has just released a position paper called Too High a Cost, a Public Health Approach to Alcohol Policy in Canada. On slide number 10, I've listed the recommendation regarding the contribution of alcohol to chronic disease. Some recent activities of the National Alcohol Strategy Advisory Committee. The first and the most time-consuming project that we've undertaken so far is the development of the very first set of pan-Canadian alcohol drinking guidelines. These so-called low-risk drinking guidelines were given the green light by federal, provincial, territorial ministers of health in November of 2011. They replace all 4 existing sets of guidelines in use in Canada. They're the first evidence-based, peer-reviewed national guidelines. Knowledge exchange materials are being developed and they will be released in March of 2012. Refer to the website of the Canadian Centre on Substance Abuse, ccsa.ca, for all the materials, including the scientific paper on the review of the science on which the guidelines were based. The low-risk drinking guidelines will be incorporated into a screening and brief intervention tool for physicians, which is currently in development by the committee. This slide, number 12, lists the advantages of the low-risk drinking guidelines, and enabling consistency, increasing social awareness, allow health professionals to advise their patients, and will help us with data collection. The guidelines are low risk, not no risk guidelines. Any consumption of alcohol puts the drinker at some risk. The guidelines are not goals. They are what we are calling ceilings, not floors. So I've talked a bit about the global alcohol strategy and the national alcohol strategy, and now I want to turn to activities in 3 provinces. Many provinces have incorporated alcohol into mental health and substance use or addiction strategies where the connection to chronic disease is often not made. But Nova Scotia is the very first province with a specific alcohol strategy, released in 2007. On slide number 14, I've listed the strategic directions in the Nova Scotia strategy. Again, the strategic directions I have highlighted are the areas where collaboration with chronic disease networks and organizations will bring synergy. Alberta is the next province to adopt a specific alcohol strategy. Again, the highlighted strategic directions are those that will be enhanced by collaboration with chronic disease networks, the chronic disease community. Slide 16 shows the interconnectedness of alcohol with many other issues. This is from the Alberta Alcohol Strategy. This panel, the 4 speakers on this panel, recommends a specific alcohol strategy as opposed to embedding alcohol in other topics like a chronic disease strategy, and we particularly like the Alberta model. Action to reduce alcohol-related harms and costs can occur if alcohol is positioned appropriately within chronic disease strategies, public health strategies, mental health and substance use strategies, provided that, 1, problematic alcohol use is not seen as a mental health diagnosis. Number 2, the role of policy and other effective interventions, as discussed by Dr. Strang in his slides, is acknowledged. Number 3, linkages are made to the burden of illness in Canada from alcohol, which are both injuries and chronic diseases primarily. And number 4, addiction or dependence is not the focus. Now, turning to my own province of British Columbia, alcohol action is embedded in our 10-year plan for mental health and substance use in the province, entitled Healthy Minds, Healthy People. This plan focuses upstream with more than half of the actions directed at prevention and health promotion, and it is designed both to improve health and to transform systems, and its third objective is to reduce costs. Milestone number 3, which I've listed on this slide, slide number 17, specifically addresses alcohol. Slide number 18 is a chart or figure which we have used in our 10-year plan. It shows the rates of hospitalization attributable to tobacco and alcohol use in BC. A picture's worth a thousand words, as they say, and this particular snapshot in time illustrates the successes we've had in addressing tobacco dependence, which have been achieved through a combination of policies oriented toward treatment and prevention, and without criminalizing or punishing people who smoke. However, it also shows that we need to pay attention to alcohol use and not just chronic dependent use, as alcohol-related hospitalizations are projected to surpass tobacco-caused hospitalizations in 2013 or 14. I am quite sure that there is a similar picture in all jurisdictions across this country. Slide number 19 documents some research in BC conducted by the Centre for Addictions Research BC. The messages here, which have been demonstrated many times in the literature around the world, are: 1, when availability increases, i.e. when we have more places to purchase alcohol, total population consumption increases. And number 2, when population consumption increases, alcohol-related problems and costs also increase. This is why we need the chronic disease community to help advocate against increasing access to alcohol and against privatization of public monopolies. Public or partly public monopolies exist in all of the provinces except Alberta, which has a totally private system. As an example of collaboration, interest from a chronic disease network, the BC Healthy Living Alliance has recently adopted policies on alcohol as a risk factor for chronic diseases, and I present their 3 policies here on slide 20 and 21. Note in particular the policies on pricing and access. Both of these policies have a strong evidence base in the global literature and are deemed to be the most powerful, most effective ways of reducing alcohol-related harms and costs. Policy 2 and 3 are listed on slide number 20. Slide number 22. To summarize, the four speakers in this panel, Dr. Giesbrecht, Dr. April, Dr. Strang, and myself, have presented the case for action by public health and community health, including NGOs working in chronic disease prevention. We need to be synergistic in our actions in order to reverse the trend depicted in slide 18. To this end, the National Alcohol Strategy Advisory Committee will be contacting the Chronic Disease Prevention Alliance of Canada to explore possible collaboration. That might be by means of membership on the National Alcohol Strategy Advisory Committee or some other activities. Thank you very much for your attention. We look forward to working with you to reduce the burden of alcohol on chronic disease in Canada.